Hello, it's Dr. Nolan. I hope you're having a good day. Today's discussion is going to be on the compliance that we see in the heart. So we're going to cover not only the compliance of ventricles, but also a very brief discussion of alterations in compliance of the atrium. Compliance is something that I think is very important for you to know because it alters significantly the clinical determination of pressures inside the ventricle. So we're going to discuss thoroughly what is compliance. We're going to also discuss what are the differences in compliance that are found in the atriums. We also then proceed to have a more thorough discussion about differences in compliance of the ventricles, what causes these differences in compliance, and what does compliance mean to us clinically. Specifically, we're giving you some examples of how these alterations in compliance can lead to very significant alterations in our pressure readings, and also how it affects clinically monitoring and how you have to take into compliance into consideration before you make a clinical determination as to what you should do with the data that you're getting. What exactly is compliance? And compliance, when you look at it from the dictionary standpoint, it says it's a willingness of a structure to give when being filled. Another way of actually looking at this, when you're looking at the pulmonary system as well as the cardiac system, is how much volume is accepted into that organ until you see a change in pressure. When you're looking at fluids, this pressure is rapidly increased in comparison to air. So when we're talking about compliance to the lung, when we review this some more, this will come back of significance. But for now, because we're talking only about the ventricles, what I want you to think of is when you're talking about compliance, is that you're looking at how the ventricle or the atrium acts as the volume begins to expand into that space, and as a consequence cause an alteration in pressure. Okay? One of the things that we have a very hard time monitoring during our clinical evaluation of a patient is volume changes. Instead, we use pressure as our main focus of monitoring for volume changes that are occurring into the patient. So by understanding that there's differences that are due to compliance that will alter the pressure wave, it will begin to impact on our understanding of the clinical relevance of that situation. Compliance is usually monitored using a simple equation for the actual change in volume that's occurring in the ventricle. For the same period of time, for that change in volume is the change in pressure. So a change in volume over a change in pressure will give you the mathematical equation of compliance. Okay. Now, of course, you have your normal compliance, and then you have alterations that can occur. Either you can have a more compliant ventricle or a less compliant ventricle. A more compliant ventricle would be a situation where volume is easier accepted into that space with a very little change in pressure. A good analogy would be a thin rubber band that's being stretched between two fingers. As you pull on the thin rubber band, you'll notice that initially that the volume changes occur very easily without really feeling any back pressure on your fingers. But once you get to a certain point, the actual elastic components begin to compress and begin to cause pressure to increase along the fingers. So that's consistent with a more compliant situation. This would be the analogy of a thin rubber band. On the other hand, a less compliant, or what's called decreasing compliance, would be a situation where the ventricle accepts volume, but as soon as it accepts volume, it causes an immediate change in pressure. This would be consistent with the idea of a thick rubber band, whereas you try to pull a thick rubber band apart, you will notice that very quickly the pressure begins to increase as a consequence. Now, compliance, when you're looking at the ventricle itself of the heart, you have to take into consideration a little bit more than just this simple analogy of thinking of a rubber band. Instead, you have to begin to think about wall thickness. Wall thickness is an important factor in determining how compliant a ventricle is. Just simply the mass of that muscle impedes the ability of volume to expand without causing an immediate increase in pressure. In addition to that, you can also think about the the deposition of material, or the amount of fibrous material inside the ventricle, will also, in essence, impede the ability of the ventricle to dilate with volume without causing an increase in pressure. The other factor that also adds to it, it could be a density changes in the wall, and we'll talk about that in a minute, pathophysiology of it. But you can alter the density of the ventricle in some situations. The next one is a very important dynamic component that has to be thought of at the myosin head level, which is the sarcomere length. Sometimes will not be able to relax properly, so the Z lines cannot separate like expected. This can be simply due to the myosin binding to the actin filament not being able to be broken due to lack of ATP. So things that will lead to diastolic dysfunction lead to basically a decrease in compliance, because simply the ventricle is unable to relax, so the ventricle becomes stiffer. Okay, so changing the actual oxygen delivery to the mitochondria, which leads to ATP depletion, may actually affect the sarcomere relaxation phase. And the last one, which a lot of people forget about, is that compliance can also be altered in certain situations by the external pressure around the heart. It acts as an impeder to be able to relax the heart due to this external compression on the ventricle itself. Now, the right ventricle, which is usually more compliant than the left, is the one that's more likely to get affected by this alteration in external pressure, simply because it is more compliant. Now, when you look at these clinical examples in pathophysiology, when we look at those 5 major headings, we can give some examples of each. The first major heading, which is wall thickness, situations where you see a decrease in compliance, would be anytime the heart hypertrophy. So patients with aortic stenosis or chronic hypertension that develop hypertrophy of the heart will have a decreasing left ventricular compliance. As for fibrous deposition, fibrous material can actually be deposited in high concentrations in the ventricle, and it begins to alter the ability for the ventricle to relax simply because of the fibrous deposition, such as amyloidosis or some kind of proteins that are being deposited in high levels, such as in scleroderma, which as a consequence causing decreasing compliance to the left ventricle. You can also change the density of the wall. Things that occur quite often, such as ischemia or myocardial infarction, which causes the inflammatory mediated reaction to start to be activated, leads to edema formation along the myocardium. That edema formation will increase the density of the myocardium, and as a consequence, decrease the compliance. And in addition to that, besides water as being a decreaser in compliance, you can have actually heavy metal deposition or some forms of calcium deposition into the ventricle, which causes the situation decreasing compliance. Of course, the ability for the sarcomere to go into a relaxed state is critical for maintaining good compliance, and would lead to a decreased compliance would be ischemia of the ventricle, lack of oxygen delivery to the mitochondria. Could be also due to severe forms of anemia. It could also be seen in patients with mitochondrial disease states, where the mitochondria actually become diseased, either from genetic factors or from some other form of viral infection. And as a consequence, it leads to decreasing compliance of the left ventricle or the right ventricle. The other last factor is the external pressure around the heart can also lead to a decreased compliance, such as cardiac tamponade, pericarditis, which is inflammatory reactions around the heart, which causes pericardial effusions and eventually cause banding effects around the heart. You may also have positive pressure ventilation may also act to decrease the compliance of the ventricle. And you can have certain pleural disease states all the way from a tension pneumothorax to a hemopneumothorax, or any kind of fluid inside the pleural space, which causes compression on the ventricle, may lead to a decreasing compliance of the ventricles. This is a nice picture drawing showing you a situation where you have a decreasing left ventricular compliance. This drawing you can see here, the normal in the red. Okay, this is the patient's preload line, okay, which is consistent with the compliance line. you'll see that as each person changes their volume, you expect an increase in pressure to follow. As you have a decreasing compliance, you will see, as for the same change in volume, you would have a greater change in pressure. Situations that would lead to that would be, again, hypertrophy, pericardial fluid inflammation, amyloidosis, like in this picture, or inflammatory reactions or ischemic events in the heart. So all these are typical examples of decreased left ventricular compliance. The other situation I want you to look this at later on is if we have the time to discuss about pericardial tamponade, we'll notice that we also will see a decreasing left ventricular compliance due to compression around the heart, and the consequence shifts the curve upwards, and will actually fool you clinically, believing that the patient has adequate volumes simply because you see an increase in pressure. But in this situation, your volumes may actually be very, very low in the ventricle, and these pressures are simply the cause of the external compression on the heart itself. So it's not really due to the volume inside the ventricle being adequate. Now, on the other hand, with the other extreme is the increasing compliance. And increasing compliance can be in any situation where the ventricle is able to dilate. So when the wall thickness becomes thinner, so in dilation of the heart, you can actually see an increase in compliance. Usually that's not a good thing, because once the heart begins to dilate, the heart will not respond to therapeutic maneuvers to reverse that effect. So dilation is not something you want to see. In addition to that, you can also have fibrous material that can be inadequate in quality, such as in certain collagen diseases, where the actual collagen is not strong or it's more elastic, such as in Marfan syndrome or in Ehlers-Danlos syndrome as well. You can also alter the density of the wall by having decreasing fluid in the myocardium, such as severely dehydrated states. Or decreasing, you can see the changes you go from one extreme to the other extreme where you have decreasing inflammation. The other thing that's been reported recently is that the myocardium can also get fat deposition in patients that are morbidly obese, which will also lead to an increase in compliance of the ventricle and eventually dilation of the ventricle. As for to increase the ability for the ventricle to dilate itself and relax due to sarcomere relaxation, anytime that you have increased oxygen delivery or increased ATP production or increase in mitochondrial numbers, these will tend to help increase the compliance of the left ventricle or the right ventricle. The external pressure around the heart usually is under spontaneous breathing. The patient will actually exert a negative pressure, so the actual compliance of the ventricle actually improves or increases during a negative inspiratory pressure breathing. This is a nice picture showing you what happens with an increasing left ventricular compliance. And the red line is the example of the normal left ventricular compliance, followed by increasing left ventricular compliance here, which is due to either ventricular dilation or situations like Marfan syndrome. We can see that for the same change in volume, you see much less change in pressure, which is consistent with an increased left ventricular compliance. Now, what are the differences in the different atriums? Well, the left tends to be a little bit less compliant than the right. Tends to be a little bit thicker than the right, simply because the left atrium must pump into the left ventricle, which is thicker, and as a consequence, the left atrium tends to have a slightly thicker musculature lining. As a consequence, you would tend to see a little bit of a less compliance in the left in comparison to the right. Okay. The other thing you can see they can alter your atrial compliance will be alterations in the either tricuspid or mitral valve, such as in stenosis for both of them. In both those situations, the left atrium or the right atrium would become hypertrophied as it tries to pump against a fixed valvular restrictor. On the other hand, you can actually see an increase in compliance in the reverse in situations such as mitral or tricuspid regurgitation, where the actual left and right atriums in those situations would actually dilate and thin out, which would make them more compliant. The left atrium is specifically a little bit less compliant than the right because it has to pump into the less compliant left ventricle. This also accounts to a certain degree why the PA occlusion pressure tends to follow in a more linear fashion alterations in volume due to the differences in compliance of the left ventricle in comparison to the right. Okay, so if you have to really monitor for changes in volume, what's the more accurate ones to use is situations where you have less compliant ventricles or less compliant structures, because they would indicate to you rapidly for a small change in volume, significant change in pressure with it. Now, remember, both atriums have to move the same volumes, so it's not really that we're talking about actually changes in volumes. What we're talking about is that the ability for a monitor to see a change in pressure would be minimal in an atrium or ventricle that is more compliant. It's, in other words, it's able to give easier without really causing a change in pressure. So it makes it more difficult to monitor using a atrium or a ventricle that is more compliant. It is much easier to notice a significant change in pressure when the ventricle is less compliant or stiffer. Now, what are the differences between the ventricles themselves? The left ventricle, as you can see on this picture, has a concentric shape. It also has a mass that's surrounding the whole ventricle as being significant in size. In comparison, it's almost 5 times greater in thickness in comparison to the right ventricle. So, just simply from the point of view of wall size, the left ventricle has significantly greater wall size and has a decreased compliance as a consequence to that. What you see clinically is that if you give the same amount of preload volume to a patient, say you give a 500 cc preload to a patient, you will notice that the right ventricle, because it's more compliant, would tend to have that, say, from here to here, that 500 change in total volume delivered into the ventricle would have very little effect on changing the pressure. Versus that same 500 change in pressure, you would see a significant increase in your pressure in the left ventricle. So having a much more linear relationship, such as found that's in the left ventricle, is actually something that we find helpful when monitoring patients. Okay, so the reason that we use a PA catheter, in essence, is because we are hoping that having that linear correlation between changes in volume and changes in pressure will give us very reliable data. The problem with that is that the actual ventricular compliance changes in different situations. Even with having the patient in the same left ventricle, but if you put any kind of ischemia, like in this picture, you can see that the person has developed ischemia in this portion of the heart. That ventricle will actually become less compliant, and this red line would actually start shifting up in this area, and as a consequence you would tend to see, let's see if I can get it. Okay. Anyways, you would see a greater change in pressure as the compliance decreases. And it may actually make you think that you have adequate volumes in that patient, and in reality you do not. Okay? It could be that the person has a low volume state and may actually require more fluids, even though the PA pressures may be higher than you would think. So that's one thing you have to have in consideration prior to actually making the assumption that volume is what you think it should be. In some situations, the right ventricle will actually remain either hypertrophied or become hypertrophied. If you're taking care of a child that's under the age of 3 years of age, you will notice that the right ventricle is actually larger in size in comparison to the left ventricle. As a consequence, the CVP in a kid actually gives you a very nice relationship to determine preload volume to the heart. The other situation where the CVP becomes also very accurate due to hypertrophy would be somebody who has chronic pulmonary hypertension or has a history of increased resistance in the pulmonary circulation, which leads to right ventricular hypertrophy. Now, what does compliance mean to us clinically? Well, it means a lot. It means you have to really always think about alterations that may be taking place in the ventricle before you make a clinical determination if the information that you're getting is actually valid. Remember, really, when we're talking about preload of the ventricle, we're really talking about volumes, not pressures. But what we're doing is we're inferring the preload based on this simple linear relationship with changes in volume with changes in pressure that you would normally see in the left ventricle. That's why we use a PA occlusion pressure. But in any situation where you have either alteration of increasing or decreasing compliance, that assumption begins to go out the window. Okay? So you really have to really understand this well, otherwise you're going to make some critical clinical errors. Anytime you look at the situation, you must sort of take into consideration how is the compliance of the ventricle at that time. Okay, like I did a case today where a patient had a pleural effusion with a contused lung with 9 rib fractures, and we put a PA catheter during the initial part of the case, and we noticed that the PA catheter indicated pulmonary artery pressure of 45/26 with a PA occlusion pressure of only being 11. So there was a huge difference between the PAD and the PA occlusion pressure, which is not something you would normally expect. Normal values should be only different like 4 to 5, and it was differences of up to 10 to 14, which that's a big difference. And the reason being is because the lung was partially collapsed from the hemopneumothorax that the guy had, and as soon as we drained this hemopneumothorax off, okay, the ventricle was able to expand more properly, okay, and as a consequence, the actual PA occlusion pressure dropped from being 15 down to 2, and we didn't change any volume. We didn't give that patient any fluids or anything like that. So in essence, what you were seeing is direct compression on the ventricle, which was altering the compliance curve and was actually fooling us into believing that the ventricle was actually full. When we, on the other hand, clinically, by watching the actual arterial line, you could see that the stroke volume was limited, which it's just consistent more with lack of preload. So we were anticipating that this patient really was on the lower volumes than we thought. And good for us, we found that that was the case. Once this hemopneumothorax was drained, that the PA pressures dropped significantly. So and we had this discussion during the clinical time about this compliance and how these can give you erroneous numbers if you don't take into consideration the pathophysiology that the patient may have. The other thing that I want you to also think about is that compliance is something that you should always consider as is consistent with ischemia. We see an acute drop in compliance. So really, anytime you see an acute decrease in compliance, always think that the person is having ischemia until proven otherwise. So anytime you see a sudden increase in PA occlusion pressure or CVP, you always have to make consideration at least that there might have some form of ventricular ischemia going on. Any pressure in the heart may be affected by this alteration in compliance, and that always has to be a consideration. Now, why do we actually monitor right versus left heart? Is simply because of the differences in the actual compliance of the right and left ventricle. Remember that the right ventricle is thinner, and as a consequence is more compliant, and the left ventricle, which is thicker. So that linear relationship that we established with the PA occlusion pressure usually gives us a much more reliable preload determination of volume inside the ventricle. Okay? But also remember that PA catheter has its limitations, and when we talk about it over the next few hours, this will become quite clear as to why there's so many problems with PA catheters. So I hope this is giving you a little bit better understanding of how compliance may actually I'll also your readings using PA catheters and any kind of readings of the heart. Thank you. Have a good day.